Dr. John Garden. I'm the periodontist of the Head Dental Academy, and we are starting this daily periodontics clinical series videos for you, so that you can get the insight of all the treatments which are done here, which are trained here, and which are done under proper supervision academy on the patients, directly on the patients. Okay. So as you see, we have today all the equipments of the splinting. Okay. So now, what is splinting? Patient when comes to you with his mobile teeth, especially the first teeth which gets mobile is mostly the anteriors, the maxillary anterior, the mandible. Now, why they get mobile first? Because of the bone quality. Here you have the cortical bone, here you have the spongy bone, and this area is the most prominently affected by the mastication forces, by the abnormal forces. So, mostly mobile tooth you will find in patients is the mandible anterior, maxillary anterior. Now, whenever patient comes to you with a mobile tooth, mostly in his mind or in her mind, patient mostly doesn't want extraction, because first of all, it is an aesthetic area. So if they get extraction, the problem will of the facing the aesthetic in front of everybody, people will be a big problem for them. Second, if the gap is there, they will have to have new teeth, new bridge. So the cost factor is also being incorporated in them also. So they mostly want a small treatment, a mid-sized treatment, so that they can have their teeth retained, and they are very away from the extraction at least till 2, 3, 4, 5 years. So here comes your splinting. Splinting will save your teeth from extraction. Splinting will help you in aesthetics. If patient is having problem in the anterior teeth, some patient is having fracture, patient has a sudden trauma, patient has some accident, all these areas splinting will help you in a very, very faster and a very small way. Okay. So today I will give you all this demo of your splinting. So now what you will see? You have all the equipments here. First of all, these are all your instruments for the carving or for the composite. This is your mixing spatula, this is your carver, this is your explorer, this is your again carver, this is your chisel type carver. All these are the mouth mirror, the probe, the tweezer, as you know, fade shape. It's called the fade shape carver. Okay. Then you have this etchant, as you know, when you do a splinting, so you require some material to bond with. So best material to bond with is the composite. Splinting is never done with the GIC. Splinting is always done with the composite. So composite, you have the etchant, you have the bonding agent, the most important, and you have the composite. This is the packable, this is the flowable. Now always remember, you go by protocol, your treatment procedure will never fail. Etchant is required whenever you do a composite material, so that it prevents or formation of a smear layer. It is applied for at least 20 seconds, and then you clean that with a water or a air wash syringe, 3-way syringe. Okay. Then you have the bonding agent. Bonding agent is required basically so that the bond between the composite and the tooth is very enhanced. You need something to bond. Okay. So the enhancement between the tooth and the composite will bond by the help of this bonding. And then comes your composite flowable, or this is the packable, this is the flowable. Now this is the area where the problem comes. Patient comes to you with a mobile tooth, this is very, very mobile, like grade 3 mobile. So try to do with the flowable composite. Why? Because the flowable composite somewhat, it is very, very viscous and it has more volatility. So in grade 3 mobile tooth, it will have more strength. Normal cases, you can do with the packable composite. Okay. This is your applicator. Now what is this? This is the fiber splint. Okay, the fiber, it's also called the rebond material. You sometimes do splinting with a thread that is called a fiber. It gives you strength when you apply it between the teeth and the composite. Not used every time, but used in some cases of your splinting. Okay. This is your tray for the mixing. These are your erotor bars. Okay. This is your typho. And these are your applicators. So now I will give you the demo of your splinting. Okay. Now, first thing first, always have an idea how to start about it. If you have the maxillary tooth, splinting is done buccally. If you have the mandible tooth, splinting is done lingually. Now get an idea why. If you do a mandible tooth splinting buccally, your maxilla will come and they will hit the teeth. Chances splinting will get away. Same with the maxilla. So mandible teeth is done lingually, maxilla is done buccally. Okay? First of all. Then the second rule is that if you want to do splinting here, if I show the camera, is splinting you want to do in the anterior tooth, the most splinting best is from canine to the canine. Okay, why? Because the canine is the strongest tooth, it gives support, and mostly in case of patient, the lateral to lateral tooth are very much mobile. So support is always from the canine to the canine. Okay, so what do you start with first? You have the etchant. Whenever you apply the etchant, you have to apply on the all the areas of all the teeth. In this case, I am giving demo from lateral to the lateral. So I am applying this etchant. Okay, see, you have to apply it on the all the areas. Okay, and this you can spread it in all the areas by this help of this applicator. Need not to put the material in all the tooth. Spread this material only in all the tooth survival. We'll keep this applicator here and we'll take some cotton. This is a typho, so we can have some cotton also in case of the water. Okay. Then you inspect it how the HN is removed from the all sides. From the all sides. If you think there is some liquid elsewhere, again try to dry it. Okay. Now it is dried. Now what is the second work? That is the bonding agent. Now always remember, any type of composite material you work in your cons, endo, you do your class 1, class 2 fillings, you do your splinting. This is the most important, that is the bonding agent. If your bonding is not proper, you don't have isolation, so you can have problem with your composite. Bonding is the most important agent used in every type of procedure. Apply bonding agent, dip it in the areas and apply on all the areas. Always remember, bonding same as etchant, you have to apply it in all the areas. Okay, the mesial, coronal, okay, distal, and you immediately cure it with your curing light. Now, this is a very big misconception or problem with us, that we always think that when we do curing of the composite, we do it random like this. Never do it randomly. It is always done 20 seconds per teeth. If you are doing splitting for 4 teeth, so apply bonding on 4 teeth, and curing has to be separate for each and every tooth. Okay? 20 seconds, 20 seconds, 20 seconds and 20 seconds. Okay? So we are curing the third tooth, and then we will end the cure the fourth tooth. Okay. 20 seconds is the timer you have set for the complete curing, and then you have to set and spare each and every tooth for the cure. Okay. Never do it randomly. Sometimes the bond doesn't get set. So try to do it separately on the each and every tooth. Okay. So now I think we have now completed our curing. Okay, now you see the main part, that is your composite. I am showing you the demo today of the packable composite because it is more difficult to cure it, more difficult to trim it. So in first video I am showing you the packable composite demo. Okay, you take out the composite as you feel how much it required. First of all, this is we are giving demo of your plain composite. Okay, you just apply it randomly as you think you are fine. Okay, now what you have to do, remember always, composite has to be secured in all the areas, right? Example, this tooth is mobile, you are 314. So I am taking support from this one lateral to one lateral. Okay, so you have to trim this composite, apply it on the all the areas in such a way that patient should not feel anything extra on his teeth. Okay, I will request the Idris to show the area of the composite which I am trimming it, so that you all can see where we are applying and how we are applying it. Okay, it has to be very smooth and aesthetic also. Okay, trim the composite, make secure the composite in such a way that from the front tooth it shouldn't be applied like something has been applied on the tooth. It should totally look like a tooth shape filling is been there, and totally shade, color and aesthetic should be matched. Now this is just the initial filling. Okay, now what we'll do, you have to trim this. Okay, why trimming is important, I'll show you. If you don't remove this coronal part, patient will have top of occlusion, he will have the opposing point, so you have to clear the coronal clearance. Remove the coronal as much part as you can, first of all. Now if you leave the cervical part, he will have full lodgement, so you trim this main, that is your cervical. Okay, remove the extra so that at least food can pass all along the areas. Trim it, press it. Okay, now something is left on this, or should we do something more? The most important point, interdental curing. See, you have to take a straight probe, and what you do, this is the main point, interdental locking. This gives a patient a tooth-like feeling, and he will have no over contacts, he will have no over feeling that something has been applied to my mouth, I can't open or close my mouth. He will have a perfect feeling, and the splinting is also protected in a normal way. When you are sure that my occlusion is fine, my cervical is perfectly fine, interdental, the composite has gone. This is the main thing, composite should go internally. When it will go internally, it will hold the composite. And when you are sure it is perfectly tight, internally lock, no contact internally, then what you do? You cure it again 20 seconds per teeth. This is the most commonest splinting in the clinic, that is the plain composite splinting. Okay. Always remember the basic steps. HN you have to do 20 seconds, then you have to do the composite. Okay. HN should be remain for 20 seconds, and then you have to clean with the water. Okay. Then bonding, always remember, never do it randomly. Do bonding 20 seconds, curing each and every teeth. Okay. And then the main part, the composite. Now it is your choice if you want to do fiber splinting based on how much the mobile tooth is, or if you want to do the composite splinting. And in the end, curing, shaping and trimming is very, very important. Always remember. Check the occlusal contacts, the coronal part, the gingival part. It is not creating interference. And then when you think that composite is perfectly fine, you can cure it. Still more is needed in this and then. We'll see after this curing that if there is some high contact, we'll try to trim it. Okay. So now you see it is perfectly cured. Now example, he is a patient. So what we'll tell him? We'll tell him to close the mouth. We'll check for the occlusal contacts. You will take a arithmetic paper and you keep here and you will check whether there is some occlusal contacts. If there is no contact, then what you will check? You will take your glove fingers and then you will check whether there is something high point or occlusion or some types of thickness is there which patient can have problem in the future. So what you will do? You will take your flame shaped burr or try to take a very small burr which will not create pit. Remember always, any type of finishing is done with a very, very basic burr so that doesn't create a pit. Okay, so we'll try to trim it. And there is no over contact, perfectly cured splinting, corner is away, cervical is away. So this is your plain composite splinting. Now this completes your splinting. Now what is left? You need to give some instructions to your patient. What instruction you will give them? First instruction is that patient has to take care of all the areas. How to take care? He doesn't have to brush apply on the buccal and the lingual surface. At least 1.5 months. He will brush all the area, but not on the buccal and the lingual where the splinting is done. If he brushes it, the splinting will come out. At least 1 month he has to maintain this technique. Second, he will not eat from the front side. Example, he's eating an apple, he's eating a guava, he cannot do that. Because his tooth is already weak, if anything happens on this teeth, the splinting will come and the mobility will increase. So 2 instructions, no brushing for 1 month, buccolingual, and nothing to be eaten from the buccolingual at least from 1 month. And then you will recall the patient after 1 month to see what is the condition of the splint, how patient is compromising with your motivation and the treatment plan, and then you have to do the follow-up. Okay, at least 1 month follow-up has to be done in case of this splinting. And then after that you can take an X-ray of the bone condition, nerve condition. If the patient agrees, he can also have the bone grafting also. Okay, so I hope this video might have some insight on you of what splinting is, what are the materials required. Every week we'll bring one video of you enlightening all the treatments which are done here, which are done under the proper faculty supervision, and they are directly done on the patients directly. There are no dummies here. Typho is only for demo purpose. We do directly on the patient. Okay, thank you.